Well, good afternoon, everybody. Thanks so much for being here and spending time with us. For those of you who haven't had a chance to meet yet, my name is Jonathan Wolfe. I am the Senior Director of Partnerships with BMA, and what that looks like on a day-to-day is I get to work with so many of the great folks in this room, our allies, on BMA's policy goals and our advocacy work. We have just a great conversation teed up with Dr. Darwin Hale, who is the founder and CEO of Advocate Health Advisors. But before we jump in, though, I need to take a moment to share with you all that Advocate is the executive sponsor of this year's forum. So if you all please join me in a brief round of applause for making this day possible. So today we're going to look at a couple of things. One, how Advocate as a company came to exist. And then it is my hope that we'll have a really thoughtful conversation on the role of community-based agents, some of the really unique ways they can solve some of the complexity issues in the Medicare Advantage environment, and really make just the suite of coverage options available to people a strength of the program, not a weakness. So without further ado, Dr. Hale, I will turn it to you to introduce yourself.
Thanks. I'm Dr. Darwin Hale, and I'm from Florida, born and raised, have 3 kids. My first interaction in healthcare was when I was young. I was a staffer for a senator in Florida, and I got to research national healthcare policy, and so it was a whole big world, a lot of interesting questions. Later, as I moved on to my career at IBM, we started looking at non-computer devices connecting to the internet, and that allowed me to sort of stake my claim as the healthcare director at IBM. That was back before CMS when it was HCFA, and IBM outsourced the claims. We did the claims processing back in the day. So learned a lot. Some of the people that did wonderful things, mentored me and told me great stories about HDX. If you don't know HDX, he said, son, the landscape is littered with skeletons trying to do what you want to do. And he said, I remember in 1960, we tried to make HDX. And so they were trying to connect doctors and hospitals all the way back in the 60s, as far as I can tell. AT&T bought that division of IBM. I got to interface with the Fortune 500, I learned a little bit more, and held P&L eventually, and then started Advocate.
Yeah. Well, speaking of starting Advocate, what better place to start? You had a really interesting personal journey that intersects with why you decided to start the company. So could you share a little bit about that personal journey, some of your experiences with your family, and how even probably to this day that shapes the way you all work with Medicare beneficiaries? Yeah,
and it hints to something I left out. I have a military career that was on and off for 32 years, active and reserve time. And so, I was sitting at IBM, or I was at AT&T at the time, and feeling pretty good, had a good office, had a good job. And so my mom calls, like, moms do, and she's like, hey, I got a question for you. I got this Medicare paperwork. And so, to be honest, I couldn't make heads or tails of it. I was trying to help her make a good enrollment. I didn't know anything about insurance. So called a buddy of mine who I knew from the military, trusted him, as military fellows do. And so we sat down at the kitchen table, figured it out. Made a good choice. I got deployed, went away a year later or so, came back, found out she was in a different plan. It was, quote unquote, bad insurance. And, that irritated me. I was a military police officer, among other things. And so I was trying to find the criminal, right? Catch the bad guy. And really couldn't do it, right? They weren't at the same place, yada, yada, yada. So fast forward that, and I saw an opportunity, that needed to be filled. And it was sometime later before I started the company, but I knew that a lot of people didn't have a friend like my buddy Nick that helped me, or have a son that could have those resources. And so that's kind of when I got the idea to start the company. And the model, was formed out of a legacy of military and IBM and AT&T, and I brought a rational model to it. And, to me, it was sort of like looking at the supply chain and then mapping out the steps, right? So obviously, emergency rooms are suboptimal to a primary care doctor. So if you could avoid that, that's a good thing. That's pretty straightforward. And so if you look at all the people in the industry and you designate their share of the task ask, what should they do? How much should they do it? It turns out brokers are in a really neat spot, and the broker support organizations that nobody even knows what they are, what they do, but brokers don't grow on trees, and so there's some teamwork there to help the client, and that's where we built the business model.
So it started, in a very personal way, and I know, we are in a world of AI tools and chatbots and web platforms and Plan Finder, but your model is still very personal. It's very human. It could be a choice made over a breakfast table in a diner with the beneficiary. So can you talk to us a little bit about your agent's work educating beneficiary, how you all guide them through your choices, and why that very personal, human-centric model is so important to help folks feel empowered as they look at these decisions versus overwhelmed?
Yeah. Well, and you said two things there that really. So I live in Venice now, and so you sit in a restaurant, like say you're at Luby's, you hear two people talking to each other about like, this is what you do, right? And you're like, oh, but that's not what you do, right? And so they're well intended, but people try to share, but people are alone in their decision-making process, and they reach out to whoever's available, and there's not really a rating scale to say this is a 5-star broker. So there's a lot of great ones out there, but you kind of get what you get, and so. The thing to me, and I heard the personal story that someone shared here where she's championing her own mother's well-being in the hospital, right? So that's what makes it personal. It's somebody's mother, it's somebody's grandfather or father. And so when you look at the real life stories, these are consequential decisions, right? Not all hospitals are the same. Not all doctors are the same. Therefore, these choices matter. And so what I did, believe it or not, at the age of 50, I thought I was onto something after, some time in the company. I went back at a USF, an accredited school, and I got my doctorate in my dissertation was literally on broker quality in the Medicare Advantage industry. And so what we did, just a short version of it is we did a lot of research, and we realized that there wasn't any information on the brokers. There were longitudinal studies about why people enroll or disenroll from Medicare, 10-year studies, and nowhere in there did it mention the broker. Like, when you write a research paper, there's a part where you would say, these were some of my limitations. I would have interviewed more people, but I didn't have any more money. Or you say the future person who would pick up the study, they might want to look at the broker. So it's like no mention. I call them brokers. Technically, an agent has a meaning, a broker has a different meaning that we use interchangeably, but they're technically brokers. And so I went back and I looked through the research, as you have to do. There's different components to a dissertation. And we interviewed hundreds of brokers. We recorded it. And then we used Otter AI and other analytical tools to try to categorize the best practices. So we saw some of them were good, some of them were bad, some of them had good retention, some of them grew. So we put them into these buckets. And then we looked at the top percentile and we said, well, what could we learn here that would be something to look for, and maybe even build a yardstick for quality. So I built the best practices model, and then I built a rudimentary yardstick so you could have some way of telling, well, a good one from a bad one, just like we have a star rating system or the Leapfrog ABC, for hospital. So just something to sort of bring the broker into the community so that it would be something you could depend on. And a few highlights from that are that, number one, brokers are an additional resource in a resource-constrained industry. Number two, they actively market and are engaged in the communities they serve, right? So they go to the food pantry, they go to the church, they do Medicare 101s, and so they're active. And I think, I can't prove this, but my instinct is that they have accountability being part of the community, right? They see their neighbors, word travels fast, they're known, and get referrals from other people, because when you behave properly over 10 or 20 years, people know you, and it's a good service. They also, at the enrollment, they front-loaded a lot of energy, did a lot of lookups. Really, they built trust and rapport. A lot of them said, if you care about retention starts at the sale. And they were very astute socially to make sure that the client was comfortable, just comfortable in terms of not nervous energy, and they would talk talk to them, and that trust ultimately allowed them to understand the needs better, to meet the needs better, and then to match them to the resources in the community. And remember, it's not just the Medicare Advantage plan that's there. There's pharmaceutical assistance programs, there's qualifying for Medicaid, there's a whole ecosystem out there, food pantries, community-based services that they need. And so they're really kind of right in the middle of that.
Yeah. Well, let's dig into that complexity piece that we referenced at the top of this a little more. So open enrollment starts today. It's going to be it's your Christmas morning, so thank you first and foremost for being here at the start of open enrollment, being in the line of business you are. So as seniors are making their choices, it's going to be natural for some folks to feel overwhelmed, much like your mother when she started this process. So what are some of the traits of trusted agents that you all look for and you look to cultivate in folks? And then the second piece being, as people are navigating these complex decisions, I would love for our audience just to hear from you at length just how you see brokers as a really key piece of this puzzle in turning complex and tailored care options into a strength.
Yeah. Well, and ultimately it's about outcomes and it's about satisfaction, right? There's a relationship, and there's a relationship too between setting good expectations. It's not just about education. You set expectations, and there's research out there that says, like for knee surgery, there's people that had inferior procedural results, but they had better expectations set, and so they had a worse outcome on the operation, but they were more satisfied because they felt good about it, right? So we want to make sure we understand satisfaction and expectations are also important in relationship. I made 3 slides. I'm not usually a slides guy, but insurance is so complicated, I just thought a few pictures would help. And so the first one that I want to show is a picture of the industry where you think about group insurance or you think about the different types of insurance. This clicker's not, there we go. It's a delay. So most people are familiar with insurance. I mean, if we said the healthcare industry isn't only doctors, you would go, well, yeah, there's hospitals and there's pharmacies, and the pharmacy guys think they're a pharmaceutical industry. So in healthcare, each of the different groups, it's more than just the financial equation. And so I would view, hopefully you can see the slide from the back. I think you can. The first thing I want to say is that each one of these groups, let's say Medicare and Medicaid, people move in between the groups, but they all have a rule set. On the right, you see the carrier evidence of coverage. But think about this. What if you move from an employer-based plan, which is common, the most common, and let's say you go into Medicare, but let's say that you also qualify for Medicaid, but let's say you also are a veteran. So now you got Medicare, you got Medicaid, and you've got the VA. VA is a completely separate set of benefits earned by their service. And now if you look at the bottom, you see those little wheels, that's meant to be the network, right? So that's the doctor, the hospital, that's the, quote-unquote provider network. Well, that evidence of coverage, that carrier document, 250-page document, that's sort of the rules about how you access that. Now, they're not trying to block you out. They're trying to be very judicious, right? If you go to the all-you-can-eat restaurant, you tend to not be as efficient, with the food, right? So we want to get the most amount of wellness out of each dollar available, so you have to be judicious in how you match that, and of course, that becomes cumbersome. You can't really navigate a 250-page document by yourself, which is where the brokers come in. The summary of benefits is 30 pages, right? To me, a summary is like a paragraph, an abstract. And so it's not meant to be complex, but it works out that way. But think about it. Complexity isn't bad. How many types of cereal do you think there are in an average grocery store? I'm fascinated with grocery stores. Give me a number. 250. There's some 5,000 if you count specialized stuff in the internet. If you Google it, 250 types. How many types of tomatoes are there? 10,000. Google, fact check me. And that isn't the 6 different ways they're prepared. They could be peeled, they could be stewed. There's like 7 different ways to prepare a tomato. How many different types of shoe sizes are out there? How many shoe sizes? Yeah, well, that's very close. That's right. So you've got 5 to 15 through men, 5 to 12, and then in the other, you've got like toddlers, you got 4 to 8, and then you've got A, double A, right? So there's 50 to 100 different shoe sizes, if not more. Nobody's complaining about simplifying cereal choices. Nobody's complaining. If you get down to the aisle in COVID, if they didn't have my cereal, I ate something else. Like, I like what I like, and that's what I like, right? And so now this is just cereal and shoes. Imagine if it's a life-impacting thing, right? So the complexity that's inherent in that isn't necessarily bad. That evidence of coverage is how we say, oh, I'm sorry, you can't have the walker, and I'm sorry you now need a walker. You can't have the one in the pharmacy window, but I can get you the exact same one in your home in 2 days, and you're going to be fine, right? And then, of course, that cost of fraction. So there's cost containment, there's efficiency. There's only a few real levers you have to compete or to become more efficient. You have responsiveness, and they all go together. You have quality, right? You don't want to jeopardize the quality. You have to have a certain level of quality. You have efficiency, and then you have innovation. You can innovate something new, which is why we need to collaborate. And so when you think about those different groups and the fact that a person can be in multiple buckets of benefits at the same time with different rule sets, you have to quilt that together. You have to say, oh, you should get your drugs from the VA, but you want a Medicare Advantage plan because there's going to be an increased access to the routine care, or maybe you can get some tests and you can get some preventative things, and then you can go have that at the VA. Or maybe, guess what? I think you qualify for Medicaid, which is a state-run program. Let me help you get qualified for Medicaid. No, by the way, there's the other thing that might benefit you too. And so that's like the essence of the value. And then the way that plays out, though, is you have to remember health outcomes are more often created outside of the doctor's office than in the doctor's office. And that's part of the big shift to value-based care, which Medicare Advantage epitomizes. It's kind of fun because I see all the press and it's like, yeah, value-based care, these innovative models. I'm like, Medicare Advantage has been doing this for, since I started the company in 2005. But what's the secret ingredient, right? How does that really work, and how does that relate to the broker? So I think the rest of the boxes on the slide are self-evident, right? Your behaviors, what you're eating, how you're performing, if you have clean or dirty water, if you have, good policy, right? A lot of policymakers here. If you don't have good policy, you're not rewarding the right behaviors, that's pretty low-hanging fruit. And so when you look at where outcomes are created and you look at the non-clinical factors that have clinical impact, you now come to Medicare Advantage. And I think of Medicare Advantage as a wellness portfolio. And the wellness portfolio is nutrition, it's a health plan membership. By the way, a lot of people that join health plans, they go to the health plan because they're lonely, not because they want to go work out, right? So there's a social component. Quarter of seniors live in isolation. So to me, the wellness bundle is going to involve the pharmaceutical, the primary care doctor, the specialist, the hospital, durable medical equipment, and you name it. It goes on and on from there, right? And so when you have to have expertise in the major chronic conditions, you have to have the vocabulary of all the pharmaceuticals. You have to understand all the different retail outlets. You have to understand which drug category that drug is in, because it could be level 4 or level 2, so there's an economic impact. So the average broker has to have all that working knowledge. And we're really trying to get this, there we go. And so to me, if you look on the left side, you've got a community-based broker, and we talked about trust, and we talked about the needs analysis, and we talked about how they, really understand the local landscape. Not which provider is good, but also which provider has maybe a friendly front office, right? Things that don't always show up. And so they have that local knowledge, which is good. If you boat, you understand, you want to know the local knowledge of the water. And so they do that matching, that goodness of fit. But because of the complexity, I told you about that 200-page document. If you look in the middle, and there's something called Metcalfe's law when I was at AT&T, and it said when you add one endpoint to a node of endpoints, it's exponentially more complicated. So what does that mean? Well, that means if you put an acupuncture or a chiropractic or a dental benefit in a national plan, it's exquisitely more complicated to manage that. And so what happens is, after that goodness of fit, a large amount of the work of the broker and the broker support organization together, it's helping you stay in. It's helping the log jam not get jammed up. Because if the provider and the payer are pointing the finger at each other, the beneficiary doesn't really have the wherewithal to break that log jam. And sometimes, quite frankly, the broker doesn't either. Brokers do a lot of great things every day, but it's like the old help desk. You got like tier 1, tier 2, right? Is it plugged in? Reboot, tier 1. Okay, next station. And so we need that escalation path. And so that ends up with better outcomes. Those outcomes ultimately are a function of the wellness portfolio and the goodness of fit. So guiding them towards quality, guiding them away from the known defects in the system, and front loading it. I think that's a really big deal.
I love the matchmaker analogy for brokers. So when you think about the healthcare landscape today, what are some of the reasons that are top of mind for you as you're on the front line serving seniors, connecting them to the coverage that's best for them? What do you see as some of those powerful benefits for seniors in the MA program? And as you're having conversations with policymakers and folks on the Hill, what are some of your messages on why it's so important to protect the program and continue to support it in the years ahead?
Yeah. Well, I mean, I think we've seen a lot today on what people enjoy. We had testimony. And so obviously, the OTC cards might be a hot topic, but people really like them. But I'd rather focus the time on strategically, what have we got? First of all, the Medicare Advantage infrastructure helps us get the most amount of wellness out of each dollar available. And that's really the name of the game, right? We've got national security issues. We got lots of stuff we need to do. We've got people getting older, getting sicker faster. And we've got more that we can do for them. We've got medical breakthroughs. We've got scientific breakthroughs. And so we want to get the most amount of wellness out of each dollar available. And so Medicare Advantage is great at doing that. And the rewards and the incentives are aligned. There's room for improvement for sure. And there's bad actors that we got to take out. But think about it. If a plan delivers better, they have higher star ratings, they have more quality, they have more profit, they can invest that profit into enhanced benefits. So it's a virtuous cycle. People get more. That's how they created vision, dental, and hearing benefits when they didn't exist in the first place. And so when you look at that, I think that's good. I'd also say that there's a national infrastructure in place. So a lot of people, anybody that wants to, we got to eliminate this, we got to eliminate that. Healthcare is a team effort. We all have to play to the top of our game, perform to the top of our license. There's no reason a primary care doctor has to worry about doing a health risk assessment. A broker or a broker support organization, we can have all that stuff done before they ever show up. So you've got all the information as a caregiver. We can order medical equipment. We can order blood pressure devices. You can have the whole thing, because if you front load that and you do the things in the beginning of the value stream, everybody else will cascade down and do that. And so I think that infrastructure is there. And then lastly, I would just say it's poised to evolve, right? Any advances we want to make through collaborating, we're set to do that. And let's not forget, they're a consumer protection, right? So right now we got some real challenges with the commission issues. There's 1 million people affected by a service area reduction. So who's out there fixing that right now as we speak? And who's been doing that for the last 2 weeks since October 1st? The community-based brokers, right? So now you've got an inherent problem because let's just to the question, they're a consumer protection. They're a safety net. And when 2 million people had to be redetermined for Medicaid and didn't know what to do with a letter, it was a broker out there in the home. When people get moved off of a plan and they get duped and they get a $900 oxygen bill because someone didn't do a good needs analysis and they're crying, it's a broker in the home that rights that wrong, right? So they provide a very invaluable function. And the consumer protection is the one. And along those lines, I just want to say, let's be careful we don't break the infrastructure. It takes a doctor 2, maybe 3 years to really stabilize multiple chronic conditions, get the meds right. I was talking to someone today, and her folks had 20 different doctors, and they cut it down to 10. But there's a lot going on there, and so if if we don't collaborate with the government and then they make rules, those rules impact the plans. And we've seen this over the last 30 years, 3 times, right? We saw it with ACA, we saw it before with Medicare Plus Choice. And so you have to understand the timeline and the impact of the beneficiary. And that only happens through collaboration, right? Because I can't know what many of you do in the room, but we have 300,000 people and we're in the homes of those beneficiaries. We call them clients. And we know firsthand how the system works and how it doesn't.
All right, we've got time for one more question, and then we're going to open it up for Q&A with the audience, so we'll get some thoughts ready. So BMA is, first and foremost, a policy and a policy solutions organization. We're always keeping an eye to the future, trying to think about where we can take the program collectively with this brain trust in this room and ways we can make the program stronger. So from your seat in your work, what are some ideas that come to mind for you in that space?
Well, first I would say consider all the resources available. A lot of people, they sort of make the decision in the stovepipe. So you've got 1 million life and health agents in the country. You have 100,000 of them, plus or minus, that participate in the program. They're not really in the flock. For years I go to these events and they're like, what do you do? And it's like, why are you here? Why are you here? What is a broker anyhow, right? So you know, the person in the home who's first on the scene when people have questions, before the doctor's picked, before the health plan is selected, before, right there at the tip of the spear. And they're there, if they do it right and they build that trusted relationship, they're there along the way because they establish that communication path and people simply believe they have their best interests at heart. Seniors on average, and I'm a fan of technology, but see, it's more like today's tax day, right? So if you extend it like busy people do. So Medicare Advantage beneficiaries make a Medicare purchase decision more like you go to your accountant with a shoebox full of receipts and go, here, tell me what to do. They don't analyze data and they're not on the stock market graphs and they're like, what should I do? And you're like, well, let me ask you some questions, right? And so they really decide in a unique way. So we have to remember that. And I would also say that as you consider and more tightly integrate the broker, you got to set standards, right? I mean, it's true on the upside, brokers impact star ratings, they impact outcomes as we looked at. They impact the medical expense ratio favorably so carriers can make more money. Carriers have been in a bit of trying to gain market share aggressively over the years, and now they're having to turn towards P&L. So in that new environment, there's quality. And as Dr. Oz said, we don't want a few bad apples to spoil the bunch. And so my last comment would be there are 5 things that carriers can look at and that I hope I can work with BMA to socialize. It is number 1, the accretion rate. Accretion rates can range from below 60 to above 90. That's the plans that stick. People play games. They use weather codes to get year-round enrollment. They just throw spaghetti on the wall. That's costly. Short-term disenrollments. That is probably the worst. If you have this rapid disenrollments now. Rapid disenrollments are the worst. If you're off the plan in 90 days, somebody did something wrong intentionally or unintentionally, and it's impactful and it's very wrong. Retention is number 3. Retention on an annual basis should be 80 or above. If it's 60, again, that's a good measure of how good are you doing your job overall. And then the one they leave out all the time is complaint to carriers. For every one complaint CMS gets, which is the 5th area, CMS is up in arms, and rightfully so, but there's probably 8 or 9 carrier calls. The carriers could easily take the data and just publish a list and say, here are my standards, and one of the carriers just did that. It was a subset of that data, and they just said, listen, if your accretion is here and your complaints are here, it's a privilege to represent Medicare Advantage. And I would add to that, they shouldn't pay the same for high and low quality. So if you've got someone on the low end of the quality of those metrics and you've got someone on the high end, you shouldn't pay the person that provides no service after the sale that has a very inexperienced, they're basically an enroller at best. You shouldn't pay the same as a 20-year veteran who has stellar metrics. So that's my little soapbox speech there.
All right, so we've got 2 minutes or so left. If anyone has a question they would like to ask Dr. Hale, you can just raise your hand and we will get a microphone over to you. And I'll make one up if we don't get one.
I could have gone on about quality.
We got one up front here.
Oh, that's a great question. I wanted to say something about that. So we have a client care team that helps clients, right? And so we see clients getting into AI loops where they call in, they're trying to get an operator, and then they get to another AI loop. So AI very much is wonderful. People are going to use the new information we have, and AI is going to elevate people to higher order tasks. And I think if you look at AI as a productivity multiplier and a decision support tool, it's wonderful, and we're embracing it. But what you have to be careful, and like I said before, we don't need to replace anybody. We've got more work to do, but everybody has to hit the quality metric and play to the top of their game. And so you can't displace the human. AI is the helper, not the overseer. So we'll get more productivity, we'll get better outcomes, and we'll be able to get into higher order tasks like building trust and rapport, which makes people more aware, right? If you're in Miami and you're likely to have a stroke because you're in a particular category, there's a lot of people that don't take their medicine for, we'll just call it social reasons, blood pressure medicine because of the side effects. They're not going to tell the doctor or the nurse that they're not taking their medicine or why, but they'll tell their friend that, I want to be a little more romantic, so I'm not going to take my blood pressure medicine. So, when we can build trust and rapport and really do a better understanding, we'll elevate it. But the problem is, if we build all these systems and tools, we could also get into trouble if we just leave it to the person and we shift the burden to the beneficiary. So we got to protect against that. Thank you.
All right, that is time for now. Darwin, thank you so much for your support of the forum. Good luck this open enrollment season, and thank you for joining us.
Thank you.